So I'll be now talking about transepithelial PRK. A lot has already been talked about, so few of the things may be common. I'll just stress on the more important points. So this is available in various type of machines. The technology that we use is the Tenio2 technology of Bosch and Lomb, where we are using this transepithelial PRK, and we are getting reasonably good results if the case selection is good. And that's what we wanted to discuss, because this is now something which has come up and is here to stay as a safer procedure. Now, as I said before, that PRK used to be done a few years back, and we started doing less and less of PRK, but with time, now with the coming of this transepithelial PRK, again there has been a resurgence of surface ablation, because now with this resurgence, transepithelial PRK is giving good results in many cases where we were not able to do LASIK, and even in those cases we were planning LASIK, we are sometimes going over to transepithelial PRK. So now, in this first important thing that I want to talk about is this truncated Gaussian beam profile, because this is the profile that is used here in this technology. It simply means that the beam is flat topped and it is rounded from the corner. When this beam is flat topped and rounded from the corner, the advantage is that it is a low soft spot energy, 1 millimeter spot size, and when this happens, it has minimal thermal effects, and along with this it creates a highly smooth corneal bed, which is the necessity in these cases, because this results in highly predictable ablation patterns, and that is what we want. Again, talking about why there has been a resurgence in PRK, there were cases where we did good planning from our side, but we still found that there was ectasia in these cases, and we did not know the reason. Probably we attributed it to a lower biomechanical stability of the cornea, but we were still not sure, and hence we have been looking for procedures which would be much more safer. Along with this, there have been cases which have borderline pachydermatries, which have borderline topographies, which have dry eye, etc., where we were looking for more options, and this transepithelial PRK seems to be a good option. It is flapless, it is bladeless, it is stretchless. There is no stress on the retina. There are no flap-related complications and aberrations, and of course, there is lesser dry eye. So these have been classical indications for any PRK, already discussed by the previous speaker, and we all know how PRK is done, in which we majority of times remove the epithelium manually, and then after that we do an ablation and place a contact lens. Despite all this, we have found that there is a risk of 0.04% to 0.6% as per this article and many other articles of corneal ectasia. Now, single strep transepithelial PRK in various grades of myopia has been shown to be safe in many studies now. We can also see from this percentage tissue ablation that flap does not contribute to any biomechanical stability. So basically the flap is kind of a waste. So if we can save on this flap from being 110 or 120 microns to going down to 50 or 60 microns only by doing our epithelial removal, we save on 50 to 60 microns of the cornea. If there are no flap related, since there is no flap in this procedure, there will be no flap related complications. And corneal nerves, and talking about dry eye, we know that the corneal nerves are present in there are terminal nerve fibers, there are subfacial plexus fibers, and there are stromal fibers. And when we do make a flap, or even when we make a lenticule, we are cutting down on several corneal nerves, and hence we are landing up with dry eye. If we compare the number of nerves that are cut because of transepithelial PRK, they are much less compared to LASIK, and also lesser compared to any of the lenticular procedures, and hence the dry eye that is encountered is much less in these cases. So this is basically an advanced surface ablation where there is a combination of epithelial removal and correction of refractive error by doing a stromal ablation, and we are doing it by the no-touch technique, and because we are not using any alcohol or any other method for removal of epithelium, but we are using the laser, and in between the two steps there is a pause of around 10 seconds, and this allows a cooling time also, so that there is no haze in the future. Again, this slide was previously shown, this depicts how smooth your bed is once you do a transepithelial PRK. And in PRK, one big disadvantage had been that there used to be a hyperopia in the post-operative period, because we all know that the epithelium varies in thickness from center to mid-periphery. Hence, when we do a PRK, it used to be more of a hyperopic profile that we were creating, and hence in the post-operative period there was hyperopia. So to offset this hyperopia, we give an offset of minus 0.25 to minus 0.5 diopters, and the technology that we use from Bausch & Lomb has to give a very minimal offset compared to other technologies, because this also has another feature which is called the third layer removal, where after doing an ablation, we are removing the third layer, which is in the mid-peripheral zone. So kind of we are making it, again we are removing that, we are offsetting that hyperopic profile and making it the profile that it should be. So in Alcon and Schwitt also, the principles are almost the same, so I'm not talking about the details. Epithelial thickness is something which Dr. Pooja will talk about, but yes, just touching on it briefly, epithelial mapping becomes a very important part of any transepithelial PRK, because epithelium may not be always 50 or 55 or 60 microns. Imagine if it was something like, this is again an article from IGO by Dr. Pooja's group only, which says that epithelium can be as high as 120 microns. Imagine if you ablated, considering it to be around 50-55 microns, what your correction would be, because there would be an undercorrection. So it's not that it always is 120, this is one off case, but many a times we have found that the epithelium may be 70 to 80 microns, it may be 40 microns, so accordingly we have to make changes in our ablations. Dry eye evaluation becomes important again, because there are studies which have shown, and we've also seen, that if the blink rate is incomplete, if the blink rate is less, if there are incomplete blinks, or there is a lower lipid lead thickness, then your epithelium healing is altered, which can result in less predictable results. So we need to treat the dry eye, and then we go on with this procedure. Now, just showing this procedure to show you what is done here. This is the epithelium removal. You can see the first step and very clearly seen, and after that we go on to the second step. We can do either a ProScan, which is an aspheric treatment, or we can do a Cyoptics, which is a customized treatment, and then the most important, which is not there in other technologies, but this gives good results, a third layer removal, where we are shaving off epithelium from the mid-peripheral part also. So again, I can skip this, it talks about the same thing. Pain management is important, and the two things that we are doing differently, though we are following all the other things that are followed and recommended, that is chilled BSS, using oral gabapentin. The two things that we are doing differently are that we are using dilated proparacaine drops with a 20% dilution in lubricants, and this we find significantly cuts down on the pain. Our pain score levels are around 2. That's the pain score level, which is a much less pain score level than what happens with PRK, and hence our patients are very, very comfortable. There are patients when they come next day and we ask them, they have some burning sensation, some mild pain, but it is all bearable. Otherwise, with the PRK patients, which we used to do previously, we used to get calls at night from all our patients saying that they used to be shouting with pain, and they used to feel that something has gone wrong during the laser procedure. So, but now this is no longer happening because of this, as well as because of the AccuVeil. AccuVeil is no longer available. The Amplinox soaked contact lenses, again, which we have learned from Narayan Netralaya, which is sitting here, probably one of you will talk about it. And this is a contact lens which is soaked in this Amplinac, and 20 minutes prior, and once it is soaked there, this is put in the refrigerator for 20 minutes, and so it becomes cold also, and then we place the contact lenses. So these two modalities are really cutting down on pain. So one of the main hurdles because of PRK has been circumvented, and hence this procedure can be used more and more. So that's how we are, after cleaning with an alcohol swab, we're just injecting Amplinac into the contact lens case, and then after that we are taking out, after 20 minutes, after putting it in the refrigerator, after 20 minutes we are placing the contact lens over the eye. So the pain is also less in transepithelial PRK compared to PRK, because the denuded epithelium area is much less compared to what we were doing manually. Manually, we were removing up to 9 millimeters. Here, we are just removing about 0.5 larger than the ablation area. So it heals faster also, and the pain is much less also. And the haze is also much less. In fact, we have not seen any cases of haze till now, and probably one of the reasons is also because the pain is less, so less inflammatory mediators are there, so less chances of haze. And plus also because it's a very regular smoothening, and hence there are less chances of any haze developing in the post-operative period. So this we talked about. So finally, I would say the transepithelial PRK is here to stay as a safer procedure with much wider application, and it being touchless, bladeless, and flapless. This is something which we all have to adopt. Thank you.